So my topic is PI-RADS 3, is it worthy of targeted biopsy? And here are my disclosures. So I thought we'd start by definition, PI-RADS 3. So just to remember this, in the peripheral zone, our dominant sequence is the diffusion, and it's defined as focal, discrete, and different from the background, hypointense on ADC, and or focal hyperintense on high B value, and maybe markedly hypointense on ADC or markedly hyperintense. And you know, whenever you see a definition that this is this long, you know you're going to have a lot of subjectivity in the outcome. And different viewers are going to view this very differently. And I won't go over the transition zone definition, but it's similarly vague and subjective. So, you know, the first point is that PI-RADS is not a blood test. It doesn't yield a result with super high reproducibility, and people perform at different parts of the ROC curve. And that's going to change the outcome for different places. So, you know, this is also a chart from the PI-RADS V2.1. And just to recall that in the peripheral zone, a PI-RADS 3 lesion can be upgraded to a 4 if there's enhancement on DCE. And so that's yet another further complication to an already complex rule. And then in the transition zone, it can be upgraded if there's where the dominant sequence is the T2, it can be upgraded by a PI-RADS category 5 diffusion. So that can be upgraded to a 4. So you can see the complexity of it, and especially in a busy practice, you could see how some of these nuances could be confused, and we would get to different places. So with that in mind, I'm going to present what we call PI-RADS 3, and you may or may disagree, but so the first example is a 72-year-old male, and so there's a vague lesion in the peripheral zone. It's vague on the ADC. It's a little bit high on high B value, and its enhancement is questionable. So we call this a PI-RADS 3, and it's positive on biopsy. Here's another one that we called a PI-RADS 3. So again, it's a peripheral zone lesion, sorry. It's a peripheral zone lesion, very difficult to see on the ADC. It is definitively hyperintense on the high B, but it's not definitive on both. So the dominant doesn't really make it, doesn't super enhance. So we end up with a 3 for this. Now you may disagree, and I'm not gonna argue with it. But you know, here, for instance, is one that you might be tempted to upgrade. So it's a transition zone lesion, and this is the dominant sequence, not really super impressive. So we assigned it a 3. Now the diffusion is quite impressive, low, high, but it's not the dominant sequence according to PI-RADS. So it doesn't actually have any impact on this because it's not a 5. So there's some enhancement, but who cares? It's not in the algorithm. So there's like confusion about, you know, this is showing some high risk features, but at the end of the day, you have to call it a 3. And you know, it is a cancer, although a low grade cancer. And then this is, you know, another scenario that I want to bring up, which is, you know, we have definitive lesions here in the peripheral zone. There's no question about that. There are 4s, and they're going to get biopsied. But then you also have this lesion, which looks like you know, it could be a BPH nodule, but it is homogeneous, low signal, and it's very, you know, characteristic on the non-dominant sequence, and it enhances. And because of the enhancement, if you're calling this a 3 because of its features, then it upgrades, or it could upgrade. And this is turns out to be a Gleason 3+4. So I don't know if you all agree with what we called, and that is essentially my point, that it's a little variable, it's a little bit difficult. On a 5-point scale, you'll get a lot of agreement at 1 and 5. You'll get less agreement at 2 and 4, and the worst agreement will be at 3, right? So that's just the way all 5-point scales work. So how did PI-RADS 3 fare across the literature? So there are many ways to do this. You could do it by what you consider the best studies, or what I did here is the most recent studies. These are all within the last year, presuming that these in general people fairly well experienced, and they've been doing it for a number of years. And you have this large variability in the percent positive of clinically significant disease from 10%, sort of a cluster at 10 to 13%, to other studies that are reputable, 20, 30, and almost 40%. And so, I was thinking, well, maybe this will be reflected in what in these same studies, if you're going to be sort of hard about what's a 3, then that should be reflected perhaps in a higher 4 positivity rate. But there doesn't seem to be any relationship between there's a vague relationship between what you do at 3 and what you do at 4. So it's a little bit of a confusion. But you have to, so there will be no definitive answer to my talk, except that, also as you look at just one of these studies, one of the particularly good studies, where you look at the total number of cases, it's a 19% overall, but if you subcategorize it by biopsy naive, you don't really get huge differences. All these subcategories really don't make a difference whether you use version 1 or version 2. They're all producing results approximately the same. So there's no obvious subcategorization. But it is clear that you have to take the clinical situation into account. I mean, given that the range is between 10 and 40% of a positive for the PI-RADS 3, you can only, in my view, make sense of this by doing some triaging of which patients you're going to watch and which ones you're going to biopsy. So I would say for no added risk factors, a patient who is basically at low risk, a PI-RADS 3 is not justification for a biopsy. But if you have any of these situations where the PSA-D or PSA increases, or there's 4 or 5 elsewhere in the gland, like I showed in one case, well, you're going to do a biopsy of that gland anyway, so you might as well biopsy the PI-RADS 3 lesion. And if you have a PI-RADS greater than 3 on one of the non-dominant sequences in the same lesion, that's pushing you towards a biopsy. And so in general, we tend to do, because we have a higher risk population, we tend to end up doing a fair number of biopsies on PI-RADS 3 and not dismissing them, even though, if we had a lower risk population, we wouldn't. So my bottom line is that PI-RADS 3 is perhaps the hardest classification in PI-RADS. It's full of inconsistencies and difficulties in reproducibility, and that's seen in the literature where the cancer detection rate can vary from 10 to 40% in the recent literature. And the differences that we're seeing may, aside from differences in where people perform on the ROC curve, which is a problem, but it may relate to the a priori risk in given populations, including higher risk clinical scenarios. And I think at the end of the day, it's a clinical decision in terms of whether to biopsy or not. So with that, I acknowledge my team and thank you.